kind of review some of what Dr. Cartwright talked about. The goals of management for these patients with regards to their bladder are, number one, to preserve kidney function. And that really takes precedence over everything else. We want to make sure that we have good kidney function for a long and fulfilling life. The other ones, I think Dr. Cartwright put them in a pretty good order, although I did not have them in a specific order, would be to be dry and clean, to be independent, and to be free from urinary tract infections. Those are all, I think, worthy goals for us to have. So, Dr. Cartwright talked a little bit about proper bladder function. We want to have the ability to store urine at low pressures with an adequate capacity to allow you to go 3 to 4 hours without having to empty and without leakage. So this requires a bladder that is large enough and relaxed enough for us that doesn't leak. But it also has to have the ability to empty urine. That's its other function. And to do that, you have to have bladder neck and sphincter, those muscles that Dr. Cartwright drew, that will open and relax properly. And you also have to have a bladder that will squeeze or contract when the proper time arises. So why won't my bladder work? Or why won't your child's bladder work? Well, there are a number of different reasons. The first one can be a failure to store urine. So if you have a bladder that's too small or pressures that are too high, it will overcome those muscles that are holding it closed, and you'll get leakage. The other reason it may not store urine is that those muscles will be too relaxed and not tight enough to keep urine inside the bladder. The bladder may not work properly because it fails to empty properly, and so we need to use catheters in order to empty the bladder. That may be as a result of a bladder that just won't contract. It doesn't have enough tone to make it contract to empty. Or it may be that the sphincter and the bladder neck won't relax enough to allow the urine to flow out. So the mainstay of management is a combination of medications like ditropan to help relax the bladder when it's too tight, and intermittent catheterization to help empty the bladder when it won't empty properly. And what I want to spend a few minutes talking to you about are some of the surgical procedures that we can perform when those two things are just not working. That's right. The first thing, what's that? I have
it's an encryption problem.
Technical difficulties. Sorry, guys.
So in the newborn and infant period, if we have a bladder that's not safe, and we're worried about kidney damage, then we can do a procedure that's called a Vesa Costuming, that some of you may have heard about, or had children who have had these. And that's where you take the top of the bladder and we bring it right up to the skin level and make a little hole in it so that it can drain right out onto the skin. And the Vesa Costumy is usually well below the belly button, so that it will drain easily into a diaper. And it can be managed with diapering that way. That'll allow the urine to drain freely and keep the pressures inside the bladder low so that we don't develop reflux and so that we preserve kidney function. We don't get that dilation. This is usually kept in place until children reach school age. And it's not something that's usually a good long-term solution because at a certain point as children grow, the location at Vesa Costuming will get up higher and it'll be more and more difficult to cover with diapers. And at some point, most children will want to be dry. The second thing that we'll do, and what I want to talk about first are procedures that we do in order to relieve high pressures in the bladder. So the second thing that we can do that's a little less invasive are to inject Botox. Is to inject Botox into the bladder. This was FDA approved for patients with neurologic problems with their bladder in 2011. So it's a relatively recent development. All of you have probably heard about people getting Botox injections to smooth out wrinkles in the face. And it works by relaxing those muscles that give us those wrinkles. The Botox in the bladder works the same way. The toxin paralyzes, in a sense, the bladder to help it to relax. It can be done as an outpatient. We do it through a small telescope, so there's no injections involved. And most patients respond to it very well. It decrease their bladder pressures and increase their capacity. But not all patients are responders. So there are some patients who won't respond to it. The downside is that the effect of these injections wears off over 6 to 9 months. And so, as a result, it's not necessarily a great long-term solution. It's certainly not a permanent solution. But it can get it through. So it is something that we offer to our patients who may not be ready for more invasive procedures. The more permanent solution is probably something that many of you have heard of or experienced, and that's a bladder augmentation. A bladder augmentation involves taking a piece of intestine, it can be large intestine or small intestine, almost any segment of bowel has been used, and creating a patch with that segment of bowel and sewing that patch onto the bladder. This helps to enlarge the bladder to give you more capacity, and the bowel is a lot more pliable, the intestine is, and will stretch over time to help relieve the high pressures in a bladder that's too tight. So this is a long-term, permanent solution. And as you can imagine, having part of your intestines moved around and sewn onto something else is a big procedure. So most children who have this procedure will have a bowel prep the day before surgery. They'll have, that's about a 3 to 4 hour surgery, and then they'll spend 5 to 10 days in the hospital afterwards. There are some long-term, because it's a long-term solution, there are also long-term consequences or side effects of augmentation. The bowel will continue to produce mucus, and so you'll see mucus within the bladder when you catheterize or empty the bladder. And this needs to be irrigated generally at least once a week and more frequently if necessary if the mucus becomes thick. The mucus can make you more prone to developing urinary tract infections. It can make you more prone to having stones form in the bladder. You may be at a greater, patients who have this are at a greater risk of having a bladder rupture, particularly if they engage in rough activity with a full bladder, then that can be a problem. You can develop electrolyte imbalances because the intestine will continue to absorb. That's what it's designed to do, and so it will absorb whatever's in the urine. Generally, your kidneys can make up for that by filtering the blood and helping maintain normal electrolyte balance, but it can be a problem if your kidneys aren't functioning very well. And there's also been some discussion in the past about whether or not this may put patients long-term at a greater risk for cancer. I think that's still under some degree of debate, but it's something that we think about and concern about. So those are kind of our three surgical options for the tight, very small, high-pressure bladder. I'm going to move on and then talk a little bit about procedures to help with leakage. So we can decrease pressures, but that may not necessarily help prevent leakage if the muscles that are holding the urine in aren't tight enough. So there's a number of things that we can do, and we usually, again, will start with the less invasive things first and work our way to more invasive procedures. So there are bulking agents that have been used. You've probably heard of people getting collagen injections in their lips or under their eyelids. People have injected collagen in the bladder neck. More recently, we've used a product called Deflux, which is another bulking agent that can be injected around the bladder neck to try to bulk that area up so that we have greater resistance so that the urine gets it's less invasive. It can be done as an outpatient procedure through a scope. There's no incisions involved. I think this is better for small amounts of leakage. So if your child is having soaked diapers 6 times a day, I think the chances of deflux being successful are pretty low. If you have a child that's having small amounts of leakage throughout the day, then this may be enough to get them to a point where they can urinate. So I think that it's limited lasting value for most patients. Multiple injections are often required. And in addition, we sometimes use it to improve dryness in patients who have had other procedures already done. So if we've been able to improve them to the point where they have small amounts of leakage, we can sometimes improve that by injecting some deflux. A sling or a bladder neck sling is another procedure that we do. This is a little more invasive. We use some of the fascia or connective tissue from the abdominal wall, wrap it around the bladder neck, and cinch it up to the abdominal wall to tighten that area up. There are other products that have been used in the past to create slings. There's a better success rate than deflux. Most patients will require cathing if they have this procedure because the sling can make it difficult for you to pass the catheter, but some can still do it through the sling. The sling materials can break down over time. I've had that happen in a few patients. You develop a communication in girls because you're very close to the vagina, between the bladder and the vagina as a result of passing this sling material. And that can be very difficult to manage. The rectum is also down in that area with boys, and so that can be damaged as well. Fortunately, we tend to do pretty well, but we do see those complications. So that's an option. A bladder neck reconstruction is another procedure that we do in patients, particularly with a large bladder. You can use some of the bladder wall down near the bladder neck to reconstruct the bladder neck to lengthen it and tighten it, which will help improve the resistance to prevent leakage. This isn't a very good procedure for patients with small bladders because you have to use their bladder wall in order to reconstruct it. So if they already have a small bladder to begin with, then usually we'll try to go with a sling or some other method of improving that tone. There are multiple techniques for doing this, a dozen or more with variations on each of them to do this. And whenever there are a number of different techniques to try to accomplish the same thing, it usually tells me that no single one of them is universally successful, unfortunately. And so our success rates probably for the sling and bladder neck reconstruction procedures are, I would say, probably around 70%. So, a good third of patients who undergo these procedures will come out on the other end of them after having this work done and recovering and still have problems with leakage, which can be frustrating for everyone. And then the final way to help improve outlet resistance is to put in a device called an artificial urinary sphincter. And so it's a mechanical device with a cuff that goes around the bladder neck. There's a reservoir that's left inside of the patient's abdomen that holds saline, and then there's a pump that is typically put in the scrotum, and in girls can be put in their labia. You have to activate this pump in order to relieve the pressure that's in the bladder cuff, and that will open it up so that you can either catheterize through it or the urine will drain out. This is really the main benefit are for those who do not need an augment and can already urinate on their own. Most patients will still require cathing, and if you pass a catheter through the bladder neck with this cuff around it, you have a higher risk of erosion in a foreign body that could erode into the bladder neck and cause leakage. You have a foreign body inside, so there is a high risk of infection. And if they become infected, they need to be removed. And you also have to have a certain amount of dexterity in order to manipulate and activate that pump. So patients that don't have good dexterity in their hands are probably not good candidates for this. So one thing I want to talk about with regards to bladder outlet surgery is that one of the concerns we always have is that you may unmask some bad bladders. And so if you just tighten up the outlet so that it won't leak, you may be left with a bladder that's overactive and has high pressures. It's hard to know that on the urodynamic studies because if the bladder pressures get to a certain point, you have a low leak point pressure, they're always going to leak. So you don't know until you tighten it up that what you have behind it is a poor bladder that needs to be augmented or treated in some other way. So sometimes it's a little bit of a judgment call and a guessing game on our part to decide, does this patient need both an augmentation as well as a bladder outlet procedure? And oftentimes we'll do that because we don't want to unmask a bad bladder and have it cause damage to the kidneys. In addition, the success rate of these surgeries is improved when you augment the bladder or do something to try to relieve the pressures in the bladder. The last thing I wanted to talk about were continent catheterizable channels. And there are several different types of these. I think these are really important and can be of great benefit to a lot of patients in order to promote independence with bladder and bowel continence. In addition, it helps with modesty so that we can create a channel that's on the patient's abdomen. We usually try to use the belly button because it's well concealed in that location, or somewhere down on the lower quadrant, and if they can catheterize through there without having to take their pants down or have a caregiver take their pants down, without having to get out of their wheelchair, it's really helpful for them and for the caregivers to manage bladder and bowel that way. It also oftentimes will decrease discomfort for patients who do have sensation. So we do have some patients that have sensation in the urethra, and catheterizing can be very uncomfortable for them, very difficult for them to get hold of. And so by creating one of these, it can simplify that. These have complications as well. They can become, you get scarring at the skin level that can make it difficult to put a catheter through. And they can have kinks in them that will make it difficult to catheterize through. We usually try to make use of the appendix, which I had a great picture of. It's a finger-like projection that comes off the end of your colon over on the right side of your abdomen. We can disconnect that from the colon and insert one end of it into the bladder and the other end at the skin level. And it acts as a natural channel. It's not a part of the body that you need anyways. A lot of people lose them at some point along the line due to infection. And so that works really well for us. But if the appendix is not available, we can also use a small segment of the small intestine, and we can refashion it, reconfigure it into a channel. I'll just touch briefly on the on bowel management. We also use the appendix sometimes to create what's called a MACE, which stands for a Malone Antegrade Continence Enema. So for patients who are having trouble with constipation or soiling, we can administer an enema instead of through the bottom, which is difficult for most people to do to themselves on a regular basis. We can administer it through a catheterizable channel. Hang your bag of enema solution, tap water, or saline, and then it irrigates from the beginning of the colon all the way out through the patient's rectum. And most patients who do this find that if they do it once a day or sometimes every other day, they can stay clean by doing it. Patients who are already on an enema program and are doing well and successful with it are usually the best candidates. So if you can't get yourself clean doing an enema program from below through the anus, then you're probably not going to have as good a success with the MACE program, because we're simply administering an enema in a different manner. It's no different. From a different direction. The last, with the 2 minutes that I have left, I just want to put in a plug for transition care. I recognize we're so fortunate to have a great spina bifida program here at Cartwright Children's Medical Center. I know a lot of the other children's hospitals around the Mountain West also have these programs. And you stay with these programs from birth and get to know people. And so once patients reach adulthood, it can be very difficult to leave. If you look around our hospital, all you have to do is look at the artwork on the walls, look at the toys and colors in the playrooms, and all of it is meant to be comforting and welcoming to patients. And then when you go to an adult hospital, particularly a urologist's office, it's often full of grumpy old men with crusty magazines and things. And so we recognize that this is a big challenge. We're very fortunate here to have developed in the last year or two an adult transition clinic. Our division recruited a reconstructive urologist who's fellowship trained in all of these reconstructive techniques that I've just discussed with patients. He has an interest in patients with spinal cord injuries and spina bifida and the adult population. And he, along with Dr. Brockmeyer from neurosurgery, have developed this clinic. We've looked at our data, and in the first year they saw 33 patients. There was an average over 2-year delay, 27-month delay, since their previous urologic evaluation. So a lot of these patients had been several years before they had seen anybody at all. And over half of them required some kind of surgical intervention, whether it be Botox injections or urinary tract reconstruction or treatment for stones or a MACE procedure for their bowel. And so there is a great need for these patients, and we're fortunate to have a clinic that with faculty who are interested in caring for these patients. Spina bifida is a dynamic process in children. An annual follow-up is necessary for these children even into adulthood. Challenging children require complex medical and surgical management sometimes, but success can be life-changing and rewarding for us, for you as parents, and for families. And it's a privilege for us to work with you. I'm always in awe of the sacrifices and the work that all of you as parents do for your children.